This morning is Dr. Silverman, Dr. Looney, Dr. Rigby. They've been with me from the beginning of this when we kind of thought about how can we have fun and talk about immunology, and to people who use it so often in their practices but are not in the maelstrom of this tsunami of data that's coming out. And this year, I just asked these guys to just talk about something fun that caught their fancy over the pandemic. And William came up with this. I said, I'm just dying to hear what you're saying. I haven't looked at anybody's slide. I don't know what's going on. Everyone knows Dr. Rigby, professor of medicine, holds multiple titles at Dartmouth, and known to be a great teacher of immunology. So William, welcome back.
Thank you. Thank you. It's great to be here. My talk about the Three Musketeers started about a decade ago when I was seeing a friend of mine, a rheumatologist, and I said, how are you doing, Mark? And he says, I'm old enough to get PMR now. And I thought, so here's a topic that has just really grown into my practice. So you start thinking about these diseases and their interrelationships and their independence. You come across with really a broad perspective about how the immune response causes these diseases. I'm not going to be talking about D'Artagnan, played by Chris O'Donnell, because I just didn't have enough time. But if I did have enough time, Chris O'Donnell or D'Artagnan would be Takayasu. Okay. I have no disclosures. So today is about mysteries and more than learning objectives. And so what I want to try to do is set the table. Are polymyalgia rheumatica, PMR, giant cell arteritis, and rheumatoid arthritis overlapping diseases? And if so, how and where do they overlap? The second is, does the inflammation, besides the localization, differ between the three diseases? And does the arrival of one disease put you at risk for another at the same time? And if so, why? If not, why not? And finally, we're going to talk about the overlap of pathogenesis. So I'm going to give you, there's about 3 or 4 or 5 cases, so I want you to be thinking of your own cases, but I know you've seen these cases. 66-year-old woman, happens to be a spouse of a biochemistry professor, experiences chronic pain in the shoulder and hips every morning when she gets up. This has been going on for 8 months. It came on very insidiously. It wasn't terrible. But she had one episode where she lost vision in her eye, in her right eye. And this happened about 3 months prior to presentation. It lasted about 15 minutes. For reasons I'll never know, I would have thought she would have sought medical attention, but she did not. And only when she started having some systemic symptoms did she go to her PCP, who checked her CRP, and it was markedly elevated. So this is a patient who has symptoms of polymyalgia rheumatica, and also has symptoms consistent with monocular blindness or giant cell arteritis, temporal arteritis. So I want you to just ask a question for everybody to think, what is the frequency of PMR in patients with giant cell arteritis? Is it 10%, 20%, 30%, 40%, 50%? Any guesses? Any ideas? Is it more common or less common? More common. Good, that's the right answer. And she got biopsied, and what her biopsy showed, as I hope you can appreciate, is that she's got I'm going to try to point. Oops, nope, that was not it. What she's got is a intense infiltrate. Let's see. Oh, here we go. She's got this blue infiltrate, of which is mononuclear cells, burrowing into her temporal artery. You can see that the temporal artery has been expanded, the lumen is contracted. Out here are T cells in the vasa vasorum, who are making IL-6, IL-17, gamma interferon. And you can also appreciate that she's got giant cells, multinucleated giant cells that's forming at the boundary of the intraelastic lamina. If you look at the fibrosis, if you look at a stain, you can see this is all fibrotic. here with this yellow stain, and you can see the internal elastic lamina is starting to fall apart and is totally gone in this part of the slide. So this is giant cell arteritis or temporal arteritis. Now, the second case I want you to think about, so there's a woman with PMR going to giant cell arteritis. This is a 74-year-old minister with an acute onset of total body pain. And I want you to think about that particular phrase, total body pain. He could not roll over in bed. He could not dress himself. And it happened explosively. He had marked impingement in his shoulders. He had wrist and knee swelling, but not in his hands. We injected him. We started on prednisone, and he did great. But when we tapered the prednisone, he evolved MCP and PIP swelling, and he looked like, for all the world, like a rheumatoid arthritis patient. I know you've seen these patients. Okay, heads are nodding. So the third one is perhaps most interesting because of Lenny's talk and setting the table about COVID, is this is an 80-year-old man with a history of PMR in 2000 to 2005 or 2007. He was tapered off prednisone. He's been off prednisone for 10 years. And he gets a second RNA vaccination, which is March 2021. Within 72 hours, he has an incredible headache. Now, I don't know, I had a horrible reaction to the Moderna vaccine, but this person had headache, and not only had the systemic features, he had headache, double vision, jaw pain. He came in and sees his PCP, SED rate was 99, CRP was sky high. At day 5 days after the immunization, we got a temporal artery biopsy. And I want you to see that his lumen is totally occluded. There's an intense mononuclear cell infiltrate over here. But when we look for giant cells in that mononuclear cell infiltrate, they're not there. And that's probably because it's only been day 5. He's burrowed in and as best we understand, all the inflammation is coming into the vessel, into the tunica media from the vasa vasorum. But he doesn't have giant cells. So we have separate targets in time and space. This guy had classic PMR. PMR goes away, and then he gets immunized with spike protein, and his disease starts. So where's his PMR been for the last 5 to 10 years? That's without medication. He's no symptoms at all. And then the other question is this, is this an innate immune response or an adaptive immune response? Because where's the tinder? Waiting for the spark that was his vaccination. Remember, he had never been vaccinated before, so he doesn't have an autoimmune response. He's never had COVID. He's not having an autoimmune response against COVID, but he's getting the spike protein, and within 2 to 4 days, he's got full-blown giant cell arteritis. So think about what the antigen was, and whether what I'm going to tell you later is that giant cell arteritis and PMR are diseases of the helper T cell phenotype. They're helper T cells, CD4 positive T cells. There's class 2 restriction that occurs with this disorder, and that we're going to talk about. And think about what this is actually telling us about how the disease arises. So PMR and GCA coexistence is well described. I've listed some articles. I really recommend, of course, Gary Hoffman's paper from 2016 on the clinical aspects. There's an excellent review from American Family Physician also in 2000. But the mean age is around 70 for both PMR. It's twice as common in women. Giant cell arteritis is about 18 cases per 1,000. PMR is listed as 12 to 68, a little bit more frequent. I think the PMR is vastly underestimating what's really out there. I don't think we report it on enough. The widely quoted numbers are overlap, and they range from 50% to 90%. And if you biopsy patients with PMR, about 33% of them will have temporal artery biopsy positivity. So these diseases are coexisting in some way, not always with symptoms, and that's always what's driving our usual testing. So what I want you to think about is PMR, are these just intimately related three diseases that can go in any direction at any time based on whether they've been vaccinated, based on how old they are, how ambient, how good their innate or adaptive immunity is. And one of the things as I put this talk together, I could not but help imagine how many great clinical data have been done by physicians in various parts of the world. And I'm citing some papers from Norway and Spain. But the one I really want to emphasize is this in the bottom half of the slide. They had 163 consecutive patients with 15 years of follow-up. 90 had PMR and 73 had giant cell arteritis. 20% of all the patients with isolated PMR developed a peripheral arthritis. They may not have fulfilled criteria for rheumatoid arthritis, but they had a peripheral arthritis. And what this was similar to, on this slide, you see how long they had PMR symptoms before they had rheumatoid arthritis. You see in the red box, there's some people that had PMR for 10 to 12 years, or approximately 10 to 12 years. And many of these people, so these people are sort of simmering, waiting for something to drive this into a giant cell arteritis or rheumatoid arthritis. In this case, it's rheumatoid arthritis. And then you wonder what the trigger is and wonder where the disease was. Where's the disease when they have the PMR? Well, we know they have shoulder and hip issues, but why does it suddenly cross over and move into synovial joints in the hands and feet? I think it's fascinating. I have no idea. So basically, most of the studies suggest that most PMR can evolve to GCA and PMR can evolve to RA. It's less common. You can see GCA evolving to RA, but it's really uncommon to see somebody have bona fide rheumatoid arthritis develop PMR symptomatology. So the pathway looks like it's directionally away from PMR to other disorders. Now, what I'm going to try to tell you is that the same HLA alleles that are associated with rheumatoid arthritis, seropositive, ACPA-positive rheumatoid arthritis, are involved with PMR and giant cell arteritis. And this is a paper, again, data's been out there. This is a paper from 1992 by Wei and et al., in which they looked at their 42 patients with giant cell arteritis. And what you notice is that the group with DR4 positive has an increased frequency in the giant cell arteritis patients, and also O401. And this is what we have is that we have an association between rheumatoid arthritis with HLA-DR alleles. We have giant cell arteritis associated with HLA-DR alleles, and it's also true for PMR. But we're not seeing a lot of PMR patients with ACPA. We're not seeing a lot of PMR giant cell arteritis patients with ACPA. So even though they have genetic underpinnings that are homologous or close to each other, they don't necessarily evolve the same disease. Curious. And when you look at this, PMR will tell you goes to giant cell arteritis or rheumatoid arthritis. Giant cell arteritis can evolve to rheumatoid arthritis, but not PMR. The transition to RA from GCA is very rare. HLA-DRB1 associates with giant cell arteritis are similar to RA. And the question is, why is PMR GCA not associated with ACPA as in our classic seropositive rheumatoid arthritis? And I'd like to try to explain this to you using it for a second. So the HLA-DR antigen is shown on this slide. Many of you have seen this before, but this is a alpha helix of the alpha chain. This is the alpha helix of the beta chain. And remember, I've always argued that this is a good way to frame this in your mind, is that this is a hot dog bun with the upper half of the bun and the lower half of the bun. And the peptide that confers peptide restriction or is presented to your B cells and so forth, presented by your B cells to your T cells, lies in this groove. And it turns out the amino acids that are associated with giant cell arteritis and rheumatoid arthritis are down in this groove, amino acids 28 to 30. Now this is different from rheumatoid arthritis, where it's 5 amino acids up here on up here on the alpha helix, QKRAA at position 70 to 74, are associated with rheumatoid arthritis or seropositive rheumatoid arthritis. So said differently, it's the HLA-DR4 or DR401 is associated with giant cell arthritis and rheumatoid arthritis and PMR, but the associations differ in that the amino acids associated with PMR and GCA are amino acids 28 to 30, whereas amino acids 70 to 74 for rheumatoid arthritis. So what I'd like to, again, having you think about it, here's your alpha chain, the upper part of the bun. Here's the lower part of the bun. You have the 5 amino acids, which represent the shared epitope that's influencing whether the hot dog lies in the bun. But there's this other crazy area, amino acids 28 to 30, that have no role in rheumatoid arthritis, but seem to be associated with PMR and giant cell arteritis. So then you ask yourself, do those giant cell arteritis patients have the shared epitope behave any differently, or have the HLA-DRB1 behave any differently from the patients that do not? And the answer is no. The age at onset's about 71. The female predominance is about 76 to 82%. PMR symptomatology is very close. Permanent visual impairment was seen in the DRB1. But the duration of patients needing steroids for greater than 2 years was also very, very similar. So clinically, these are not different diseases. DRB1 does not seem to influence the disease. And if we summarize this, we say that if HLA-DRB1 is associated with, is restricted in rheumatoid arthritis and PMR and giant cell arteritis, why isn't the overlap much higher? Wouldn't you expect it to be higher? And is it simply just because that there's a few amino acids in that DRB1 that really confers a risk for PMR and GCA and overwhelms what you see with the shared epitope in rheumatoid arthritis? It doesn't affect disease severity. And then the other question you would ask is, does the histology inform our clinical response? Meaning, is if you are DRB1 positive PMR, is that different histology? And the answer appears to be not so. And if the SED rate and CRP fall, which we would expect to fall when we treat these patients with prednisone, what happens to the histology? So I want you to, another paper I'm referring to, again, these are papers that are scattered over the literature over about 30 or 40 years, and really tell a compelling story. And this is the follow-up biopsy study. And so patients with positive temporal artery biopsies were rebiopsied either at 3, 6, 9, or 12 months, and granulomatous inflammation was scored. And you see that even though the SED rates and CRPs have normalized and the patients feel great, there's still intense inflammation in the blood vessel wall, temporal artery. So in other words, that disease that was there lingers, as it lingers, it often develops. If you look at this inflammatory grade strategy, as it lingers, the inflammatory grade goes down in the people at the second biopsy, but that there's still a significant percentage of patients, 58%, still have granulomatous inflammation. So said differently, as many of you know, we sometimes confront people with normal SED rates and normal CRPs with giant cell arteritis and giant cell arteritis, temporal arteritis symptoms. And when we biopsy them, we see this fibrotic response. And this is well recognized because these are the patients who have already been treated with steroids or not really responding to steroids when you give it to them, and it's probably because it's not really an inflammatory disease, it's a fibrotic disease that transitioned to that fibrotic phase without any medical attention. So my second set of conclusions is PMR and giant cell arteritis are associated with DRB1, but not the shared epitope that's associated with rheumatoid arthritis. So all of a sudden we have, by the way, HLA-DRB1 is the Northern European allele. It's much more common there. And this all explains the distribution of rheumatoid arthritis, PMR, and giant cell arteritis in patients, people of Northern European descent. The giant cell arteritis resides with fibrosis long after the inflammatory markers normalize. And I'm going to ask anybody, does that surprise you? Well, I think it surprised me, and then until I looked at some other studies. And the question of the other studies, it involves what imaging tells us. So here's a patient with giant cell arteritis, and what you can see, by the way, please notice that the entire aorta is involved. The subclavians are involved. There's a meter of increased FDG uptake in blood vessels in this patient at presentation. I mean, it's extraordinary. 6 months or 3 months later, it's the scan, you're starting to see some normalization. You see the subclavians actually have some areas of decreased uptake, and there's progressive fading at 12 months. So we already knew that there was persistent inflammation in these patients, even though we knew also that we had normalized their CRP and inflammatory markers with prednisone or other treatments, in this case prednisone. So the next issue is, I want you to think about is the PMR and giant cell arteritis parallels, and that is the response to steroids and IL-6 antagonism. So remember, PMR is in a very different place. It's in the vasculature, but it's in other places that the giant cell arteritis is not. Giant cell arteritis symptoms are mostly in the vasculature. And the question is, does this confer a different response to steroids or IL-6 antagonism? And I'm going to leave the steroid question out. We already know that it does. But let's talk about IL-6 antagonism. First off, I want to just put this in context. I want to remind everybody the GIACTA study, where tocilizumab was studied in giant cell arteritis, and 56% of the patients were able to get off steroids at the end of 1 year on weekly therapies, 53%. So we know patients are getting off steroids. We know that there's some flare, but most of us have been generally impressed at tocilizumab and other IL-6 inhibitors. But what about PMR? Is PMR the same? Well, there's 3 basic studies out there, but the one that I think is the least ambiguous is this one done in France or Italy, randomized controlled trial, 36 patients, half get placebo, half get tocilizumab, 162 milligrams sub-Q weekly. They're all on 20 milligrams of prednisone. They all go through a forced taper without the patient knowing whether they're getting a reduced dose. And the glucocorticoid-free remission at week 16, 12 out of 19 patients on tocilizumab versus 2 out of 17 on placebo. This is very much akin to what was seen in the GIACTA study. So I don't know how much time I have, but I want to now talk about what's the thing that I found the most exciting and most interesting, which is about distinct tissue involvement in pathology. So, by the way, I highly recommend this online article. You can download the figures. It's very, very good. And this is a story that goes back to what I was talking about with the minister, but this is also other people. And I'm going to try to explain this physical finding or this symptomatic experience. People, I don't know about you, but people come to my practice and they tell me that their shoulders hurt and so forth. They have the classic PMR symptomatology. But they say when it started, they could not move. They could not dress themselves. They could not roll over in bed. Just torquing the body to the left or the right would be painful. They're very, very, and they notice then they start taking ibuprofen, some nonsteroidals, and they get better. And this patient, this was yet another one, and this is a person never been sick a day in his life, and he maybe he was just a wimp because of that, but it transitions to this incredible presentation. And what I want you to think about, and this is described in the article, is a PET scan of a woman with GCA and PMR symptomatology. The red shown here, and the red arrows shown here represent vascular involvement in the aorta. The yellow represents involvement in the shoulder rotator cuff apparatus, as we all know that PMR does. Please note that there's also, with this yellow arrow, the sternoclavicular joint is involved. And I don't know if you've seen this, but I've seen this. And please note that the hip joint is involved as well. Now, the green arrow points to extra-articular involvement. And what I want you to all notice is that the green arrow is positive in places like the pubic symphysis or places that have nothing to do with the joint. And here's near the spinous process of the cervical spine or thoracic spine. So in other words, there's uptake of FDG glucose indicating white blood cell activity at places that have nothing to do with the blood vessel. Here's another slide. This is a 55-year-old just with PMR, and the yellow arrows show the rotator cuff apparatus is intensely inflamed. They show that the hip is inflamed, just like you would expect, no surprises there. But please notice that the vertebral bodies are hot, and these are the interspinous ligaments. Please note that here is the sternoclavicular joints are hot. This is not typical. And last but not least, please notice that these green arrows, this is all around the ilium and by the ischium. And this has subsequently been studied in great detail. This was presented at the ACR. There was a group presented their data at the ACR this year, but this paper came out a couple of years ago, which found out that if you did a PET scanning on these folks, is that if you saw periarticular shoulder or interspinous bursa inflammation, along with the ischial tuberosities, which is, by the way, this inflammation right here, it had an incredibly high sensitivity of 90.9% and specificity of 92.4%. And this is basically the study. This has been confirmed by several other groups. Just to make the point about enthesial involvement one more time, with PMR, please notice that there's inflammation here right on the insertion points of the iliopectineal bursa and sacroiliac. And if you do a MRI, you see bone edema in that area. So, in other words, there's an overlap of PMR and GCA have an overlap of vascular processes, but PMR's got its own profile. It's totally different, and they get enthesitis and tendinitis. And the question I have for you to think about is, what's the histology of PMR in joints and in the entheses? And nobody knows. But there's clear that there's non-overlapping clinical elements for GCA relative to PMR, but this does not disturb their ability to respond to IL-6 inhibitors. Now, just as my closing slide, this is Len presented a New England Journal article from 2023. I just got this back a couple of days ago. This is a patient who I diagnosed as having PMR in 2005, but she had, in addition to PMR, she had abdominal and femoral bruits. No workup for that was no significant uptake with her, but the other thing she complained about was right substernoclavicular pain and swelling. Of course, I didn't know any of this. I didn't know what I was doing. I just gave her 10 or 20 milligrams of prednisone. And she did great for about 16 years. And she never needed more than about 3 milligrams a day of prednisone. It would always sort of percolate. Her CRP would sort of percolate a little bit higher than I like to see it, but she was fine. She developed osteoporosis, which led us to talk about whether we want to stop the prednisone, which she did not. In 2022, she got lymphocytic colitis, and with her lymphocytic colitis, she experienced temporal arteritis symptomatology, sort of a trigger, much like I was talking about with the vaccination in my 80-year-old man with a prior history of PMR. And I got a PET scan on her, and here's her PET scan from last week, I think. It was last week. Please note that she's got bilateral subclavian involvement, her aortic involvement. It goes all the way down. Her legs is involved. It doesn't go all the way down her arms, so you're not measuring. And this was considered low intensity but definitive PET uptake, or FDG uptake. So in other words, what I'm leaving you with the story was that patient you saw in 2000 or 2005, or the patient you're going to see next week in clinic, they may be with you for a long time. And I'll stop and be happy to take any questions.
Well, that was masterful with so many things to think about. I will mention, I'm going to do a lunchtime satellite on clinical aspects of PMR. So if anybody wants to engage more, please join me. What, the dog that's not barking, I wanted to ask you your thoughts since you've thought about this so long. And this attempts to figure out what is the trigger for this. What this, I mean, age is something, and what is that telling us? And all the efforts to look for what could happen when you combine age plus genes, but there's got to be other things. What's your thoughts?
I think age is really this unexplained variable. You don't see PMR in people. You really don't see PMR very commonly under the age of 60. But there are enough out there for classical presentations that you think. I think the genetics are not the whole story, but there's crazy parallel with rheumatoid arthritis, or crazy, I should say, overlap with the HLA-DR alleles in rheumatoid arthritis is a second fascinating thing. And then the other thing is we think, how many patients do I have out there who I think I've tapered off prednisone actually or still have positive PET scans? Who's doing those? Nobody's doing those. But so I've just become my anxiety level with some of these patients just has been growing and growing over the years. So I think it's the best I can do. Yeah, Greg.
Yeah, so I think this really, at least for me, if I understand it correctly, and I understand that I'm confused, so I always think that rheumatologists, we love to put patients into bins where we actually just have criteria and they're just syndromes. We don't really understand what the diseases are. The bottom line is, how is that different than Takayasu's?
Right. So is it different from Takayasu's? Well, histologically, there's no difference, right? And the durability or resiliency of Takayasu has been described for many, many years. The patients get it when they're 15 or 20, but they still have it when they're 45 and so forth. So I think what I want to know, and this is a variation of your question, is why is there specificity for that vessel that is happening? Somehow it's an elastic artery. Is there something about the elastin that's triggering it? And why are the cells coming in off the vasa vasorum and hanging out and increasing FDG uptake, which is a neutrophil marker, really? So it's.
But I mean, there's no difference between this PMR patient that has inflammation and a distribution in Takayasu's. And, we have these wonderful discussions about, is this GCA involvement of certain artery here or there? No, it's definitely Takayasu's. No, it's this versus that. And I think it's a continuum of things that we understand poorly, and we make ourselves feel better by having separate bins.
I totally agree. And the other thing I want to emphasize is that what happens for all of us is that once we get a therapeutic that we know is going to work for them, we put them on steroids, we give them tocilizumab, whatever it is, we stop thinking about what's really going on, right? Because the patient's under control, we'll see them every 3 to 6 months, checks their liver function tests, et cetera, et cetera, et cetera. Right? So I think you're totally correct.
Being equally confused at this point, are you think, based upon this information, that patients with polymyalgia rheumatica and or giant cell arteritis should be getting PET scans?
I'm not saying that because it's very hard to get them covered. And what we usually have to do is we have to have some sort of, am I saying that they should be done? No, I'm not saying they should be done. I'm saying you should treat the patient is what I'm saying.
And the patients who have a similar are like this but have negative temporal artery biopsies.
You could imagine you biopsy a temporal artery and you miss it.
Yeah.
Right. But if you were, some of those, and what's striking is that you miss it despite it looks like it's a field disease in all the major vessels in your chest and so forth. So no, And then you throw in the chance that somebody might go blind, and everybody gets very spooked. And so the tendency is to treat whether or not you can get the PET scan.
Thank you.
Well, I'm going to end this to transition to our break. Those of you that want to join us with Judy Barr, we're going to put her on now. Okay. And let's mingle between here and next door, and then we'll come back and start in about 15 minutes. Great. Thanks so much.
Thank you.
Okay, we're gonna get going, and first I want to extend my transoceanic apologize to Dr. Pooja Mehta. I gave her the wrong designation of her institute of origin. She is at University College in London, and I'm sure that means a whole lot over there to be. It's like saying you're at NYU versus up the street, or yeah, it's not like that. Any rate, we're going to back to our program, and very extremely pleased and honored to have Gregg Silverman with us again. As I said, for this morning's program, the rest of the program is fairly structured, and we requested a lot of things. With these guys who have been the stalwarts of this program, I just asked them to talk about whatever is ringing their chimes at the moment. Dr. Silverman is a professor of medicine at NYU and carries multiple august titles and responsibilities, and I don't know how you do whatever they're tell you that you're doing in your bio, so it's great. But he's a noted B-cell biologist and has made great contributions in diseases of B cells, and particularly lupus, and in the past number of years has segued into microbiomics and has just doing some incredibly interesting and creative work. So I'm not exactly sure what you're going to talk about today, but it has something to do with bugs and B cells and disease. So, Gregg, welcome back.
Thank you so much. And I actually want to thank everybody in the audience for coming out. These programs, these meetings are really wonderful, I have to say, just because we get to present and then we get to talk about it. And I have to say, medicine and science, the thing that makes it such a special career is the opportunity for a dialogue. And I think this really best exemplifies it. And it's so intimate, to tell you the truth. So I love these pictures, which I stole from the NYU website, because my laboratory is in the building to the left. And truthfully, I look out from my office at the view on the right. And whenever I tell people that I look out on the East River, they sort of cringe, but it's actually quite beautiful. And it is not really a river, it's part of the harbor. And the tide is insane, how quickly it moves from right to left. And also we're about 1.5 blocks, 3 blocks away from the UN, so you see different strange things happening. And then there are other people, when they're in session, they have these fireboats, Coast Guard, and everything else. You know, things are strange. I always wondered what they were looking for. Maybe they're on the defense from Al-Qaeda frogmen. I think that's my theory lately. But it's really quite fun. I'm from New Jersey, and I have to say, you know, the Joe Pesci thing, what exit? And I'm the only person I know that I was born, and Metuchen was in exit 131, and one day I went there, and now it's 132. So I don't know how you move an entire city, because it's just miles, so it must have moved a mile when I wasn't paying attention. I don't quite get that, but fun to be here and talk about science. We're going to wrap everything together into a package, and we're going to not just talk about it, but we're going to describe it. We're going to think about what we can do about it. So we're going to review developing perspectives on the gut microbiome in health and disease. And as Lenny mentioned, I am deep in the study of the microbiome, and most days I say I'm up to here in it, really. If you ever saw my freezers, you'd open the door and you'd cringe what's in there. And then we're going to talk about the central role of the gut barrier function for maintaining immunologic balance, and this is in health. And we'll talk about its relevance to disease, and we're going to talk about this really horrendous, frightening, inflammatory disease in children, MIS-C. And we'll talk about how we think the pathogenesis really works in a very provocative paper in the Journal of Clinical Investigation that suggests that it's all related to defects in gut barrier function. So this is just sort of to bring in the topic, the rise of the microbiome. When I was in medical school, probably when everyone was in medical school, you'd learn about a few cool bacteria. I love bacteriology and microbiology. And basically, they would be the bugs that cause disease and invasive disease. And the opposite is really the microbiome, which are commensals that we live with us that we need for health. And I didn't understand that that was important. And also, all of the emphasis on E. coli, for instance, as though this was this great threat to all of us. And it turns out it's a very minor component of the gut microbiome. But it just relates to our interest, has to do with it being involved in infections. It was really with the emergence of the Human Microbiome Project. And really, the great advance was the application of next-generation sequencing of PCR reactions in which bacteria that you couldn't even culture, and they were so diverse, how could you get a handle on them? You know, you think back to the days of Pasteur, and at very similar times right now in the medical microbiology laboratory, someone has a problem, they bring in a sample, a blood sample, stool sample, urine sample, and they try to grow it on different selective media and characterize the nature of the colonies and their morphology and what they metabolize. And after much effort, they will hopefully be able to characterize the dominant species. And it's confusing when there are mixed infections. And the opposite is the microbiome, where there are 1,000 or 2,000 different bacteria, which may or may not even be well understood at a genomic level. And they all live together and in health in a right balance. And they're supposed to be there. And literally, they live on every surface of your body and in you. And there are these arguments that people will say, in truth, nothing is really sterile. So since the first development of the technology, and most of the technology started out with sequencing a small part of one gene that is a basic building element of life. It's a ribosomal gene, and you need it to actually translate proteins. And the point is that there are parts of that gene that are essential for function, and then there are regions in between that have actually just diversified with evolution and separation of the species. And therefore, polymerase chain reaction can be used to amplify based on those conserved regions. And by looking at the regions in between, you can see how many different variations of sequence there are, and you can actually assign these to different bacterial taxa and different levels of taxonomy. And you have an idea of what the community looks like. It's a snapshot based on a simple, dumb PCR reaction, but it's been remarkably informative. There are many other technologies that have been built upon it, and it is really remarkable. Humans undergo embryogenesis in what is described as a sterile environment. And I know I wrote in one paper, I love this sentence, we all emerge from the sterile womb. It's like, great. And what happens next, you might ask? But the point is you're colonized shortly thereafter. And that actually makes all the difference in the waves of colonization until a balance is created. And that's actually the bugs that become dominant or not are determined in large part by things like your genetics and your immune genetics, your MHC, as well as your diet, as well as what's in mom's breast milk. And just as an aside, I think this is a great idea. You don't have to do it, but one of my most emphasized charities each year is the New York Milk Bank. They do a wonderful job for women that can't provide milk for their babies. They actually are able to obtain milk from mothers that have more than enough, and they transport it. And it's really such an essential concept. And if you think about how, particularly as Americans, we should be so proud how hyper-hygienic we are, and how I think that many people, maybe not everyone, rejected the notion that we should continue to breastfeed because that's what animals do. And what harm did we do our children? And what harm, I asked my mother, what harm did you do me? And she just didn't understand the question. But you know, I turned and I looked at my brother and I said, you know, now that I think about it, that explains a lot. All right, so I'm a living example of that. So we in fact have more microbes in and on us than we have human cells. So we're a composite entity in a Star Trekian concept. And in fact, everything that we do may be influenced by our microbes, from a metabolic, from a nutritional basis, from our immune activation levels. So I'm going to just touch upon these topics as we move on. The science of the microbiome, and looking at what the difference is if you raise, for instance, a mouse species, mouse strain that's predisposed to lupus in a germ-free environment. The study's been done looking at our classical models, and 3 out of 4 of those mice had greatly attenuated autoimmune disease if they were raised germ-free. So the bugs were essential. And there are many ways of looking at the diversity of the communities. We're not going to get that deep into this topic, but our intestines have like 100 billion or more microbial cells. That's the richest communities. They're very, very complex, not only in the number of different species, but they differ in different sites along the way. So our GI tract from our mouth to our anus all serve different functions. The most metabolically and immunologically active is the ileum, and in fact, very influenced your entire immune development by the bacteria that are there. And one of the most important lessons is these many different microbes have actually 100 times more genes than humans have. Now, this is my favorite question, maybe. How many genes do humans have from the Human Genome Initiative? Who knows? Anybody have an idea? You guys just actually care for one species? You know anything about the genetics?
23,000.
Yeah, 23,000 is correct. Okay, give that man a free cup of coffee. Yeah, 20,000, which is just puny. In fact, I think when they determined that, many people were quite disappointed. They said, all of our complexity and our advanced evolutionary state, and we only have 20,000 genes, and so little different from other higher primates. We get into this entire discussion. But the point is, all these different microbes, together, their genomics, they have 100 times more genes. And one of the ways that that's important is the idea is a species prevalent or not prevalent? Well, actually, it can shift almost on a dime because you change your diet, and the bacteria that are there will change in their relative predominance. You get the flu, for instance, really screws up your microbiome. And what those cells are doing and how they're metabolizing just can shift so dramatically based on their relative representation. And their genetics and the biochemical pathways that they can encode for can shift so quickly. So I launched into this project, into lupus, a very naive concept. And I have to say, I could give the talk, which I'm not going to give, about the microbiome and lupus, and I could either present why it was such a great idea, or I could present why it was really foolish and what a silly idea, because lupus is so heterogeneous. You're trying to look for common threads, common bacteria that might recurrently become expanded, different clinical states, and I picked the most difficult disease due to the heterogeneity, although we did figure out quite a bit. I'm not going to get into it, though. I'm going to talk about something else. I love throwing something out and going somewhere else. So I stole this slide, or borrowed it from Martin Kriegel. I'm sorry his name got cut off at the bottom. And we'll see if I can figure this out. Okay, so what this is showing you is this is the lumen of your bowel, and you have a gut barrier, and it actually has many different levels. Much of it, the barrier is by this mucus layer of this glycoprotein that's generated by the epithelial cells, and it's kind of like a force field, and it stops bacteria from getting too close to the epithelial lining where they may try to invade. But these bacteria are very diverse, and they may have different inflammatory factors, things like capsular polysaccharides or LPS or many other things, and we evolved to keep them at bay and to just get enough stimulation to be able to drive our immune system, which is here on the inside of our bodies. And the epithelial lining of our intestine, there are tight junctions. This is supposed to be a tight junction. They're really physical barriers for the bacteria to slip between them. And when it all works, we keep the bugs on the outside. We sample them a little bit, just as much as we need for immune stimulation. I like to say that in early development, there are sort of early sparring partners. They're not that threatening. They just sort of get the immune system up and running. They help the cells proliferate, divide, differentiate, turn into things like, can I go back? Okay, that's great. Into regulatory T cells or Th17 cells, and these can all be influenced by the composition of the microbial community that we're exposed to. And the barrier function is really quite essential. Again, keeping what's in our gut is really, think we're just a big tube, right? And this is true from a embryologic perspective. And everything in the gut is really on the outside. And our skin keeps the outside on the outside, and it's actually should be under control. And I have to say, there are also concepts I didn't touch upon where our microbes are necessary to digest our food, break down starches, other factors. You know, think about this is true across different species. Who does the heavy lifting for a termite? How can a termite eat a tree? Because it's got the right bacterial species that actually break down the starch. In this case, very important for generation of, in health, let's see, which side are we on? Here, we're just sampling just enough, and we're giving enough stimulation to our immune systems, but in fact, if there are too many microbes or they're in the wrong balance, they get across this barrier, and they can contribute to development of food intolerances and allergies and autoimmune disease. And I'm going to tell you about one pathway that was first discovered in studies of celiac disease, gluten enteropathy, which is really a wonderful paradigm. But it all comes down to the gut barrier. And this is a healthy gut barrier, and here's the mucus that's up here, and they're preventing the bacteria from getting in, and actually limits the entry of food particles as well. And it's because the epithelial cells have these tight junctions. And this is all transcriptomically regulated, and these are very, very effective. And when it works correctly, it limits the entry into the body and into the circulation. And when it doesn't, and there are reactions, for instance, to gluten or bad bacteria itself, or viruses, as we were going to discuss, or toxins, these tight junctions break down and things can slip through and get into our body. And think of all of the inflammatory effects that can occur if you have all these microbial substances entering freely. What should be a barrier, should be a glass door, turns into a screen door. So this is the mechanism that was discovered by Alessio Fasano in studying gluten enteropathy. And here we have, again, luckily the same orientation. These are epithelial cells, and these are tight junctions. And they're so tight, nothing can slip in between it. And this is all regulated by receptors. And one of the major regulators is this wonderfully entitled factor. It's a protein that the epithelial cells make themselves that will actually be secreted into the lumen to engage specific receptors. And when they get this signal, it will reinforce the production of tight junctions. But things can happen that actually cause an inflammatory state, and there isn't enough of the signal, and everything breaks down, and all of these food particles, people sensitized to gliadin during celiac disease or other factors from the bacteria can get into the immune system and cause a lot of immune activation. And the part that was interesting, and it's how the magic happened, has sort of evaded me, is Alessio discovered that there was an analog of zonulin, which should be acting again outside of the body and in the lumen, initially entitled AT1001. It's just a non-peptide. And it has antagonistic activity for the zonulin, and it can block the effects of all of these inflammatory factors or gluten enteropathy and reestablished the tight junctions, and it was renamed lorazepatide. Lorazepatide is an interesting compound, has not really been well explored from a clinical perspective. Preclinical phase 1 and phase 2 trials in celiac disease were quite exciting. The FDA fast-tracked it for investigation because they found that there's no toxicity, because when it works, it doesn't even get into your body. And how long it lasts is another question. So I'm just setting up the story, because what does this have to do with our diseases? So this is a wonderful paper, again, by a group led by George Schett in Erlangen, published in Nature Communication about 2 years ago, where he found that, in fact, the onset of rheumatoid arthritis. Now, we all believe that there are people that have autoantibodies in their circulation and anti-citrullinated protein antibodies, for instance, or rheumatoid factors, but they're good. They don't really have joint symptoms. They're not really sick. And we call that preclinical autoimmunity. And some percentage of those patients at some frequency that's still debated will go on and actually have autoreactive lymphocytes settle into their joints, and they'll get overt disease. What is the transition caused by? And how frequently does that all dissipate and go away? And it's hotly debated. This paper was very interesting mechanistically. About 2/3 or so of it is actually mouse models that reproduces what they found clinically. We're not going to get into that. What we're going to look at is actually the clinical data. And in their studies of people in Germany that had rheumatoid arthritis, had higher serum levels of zonulin. Now, I just told you that zonulin physiologically is supposed to act within the gut lumen. And what they found, and found in other settings too, is that if the tight junctions are broken down, something that's supposed to be within the gut lumen gets into your body, and you can measure it in the serum. RA patients have higher levels compared to other diseases that might be inflammatory, but this seems to be relatively specific. These are substantial levels. And if they look at people that have preclinical autoimmunity, they also have very high levels. And then they look at people that have established disease. This is actually quite fun, because here they have people that they identified that had preclinical autoimmunity, and they looked at their serum zonulin levels. And if they had higher levels of this zonulin, don't you love saying that? It's great. They actually will have, in this Kaplan-Meier survival curve, a much greater frequency and much faster development of overt rheumatoid arthritis. So this might be a biomarker of not only people who are at risk that you might have identified because of family members that have rheumatoid arthritis or otherwise, whether or not they're likely or less likely to actually go on and get overt disease. This, they biopsied several people, which I don't know how the heck they did that, and they found that the people that had established rheumatoid arthritis had less tight junctions between their epithelial cells, an intermediate level of new onset rheumatoid arthritis compared to controls. And I am not a gastroenterologist. I'm not going to go through the histology because I won't be able to explain it. Let me just say as an aside that it is not just rheumatoid arthritis in which there's evidence of defects in the gut barrier. Now, we couldn't get the zonulin assay to work correctly, but we may not have had patients at the right stage of disease. And all of our lupus patients in our cross-sectional study that we published a couple of years ago had disease duration mean of 7 years. But as surrogate markers of gut permeability, one is actually looking at fecal calprotectin. Lupus patients don't have colitis, right? We don't think they actually have overt bowel disease, but we found that lupus patients had evidence of this protein in their poop, which is a granule from neutrophils, which suggests that something is going on, some inflammatory process. Going the other direction, serum soluble CD14 is made in the liver, presumably under the stimulation of lipopolysaccharide or endotoxin, so that this suggests that there's leakage of microbial factors into the bloodstream affecting this acute phase reactant, and similar serum 1 acid alpha glycoprotein, which I think is provocative. It's not definitive, but it suggests this may be going on in lupus as well. When we did get deep into the poop of these patients and quantitated the representation of one bacteria that we actually find is most distorted in representation and abundance in lupus patients as they get more serious disease, And with great effort, we performed a longitudinal study, getting beyond cross-sectional studies, and we found 5 patients that we identified one time point in which they had we would call blooms of this one bacteria, rheumatic blaudia navis. Very complicated name. It's an anaerobe. It's a spore former. 2 cases in the literature of bacteremia. It doesn't really occur. But the point was, when we looked over time, we found that in these individuals, this patient named S107, my personal favorite, there was a 3-fold increase. Healthy people actually had immeasurable levels, or levels of about 0.1%. So this is 30-fold higher than a healthy person. So they had a low level and a high level. Similarly for S47, this patient went from super high to super low and so forth. But in general, their SLE disease activity paralleled the frequency of this one bacteria. And so the question is whether what's in your intestine is affecting the rest of your immune activation. We isolated individual colonies of this bacteria from these patients at times of blooms. We sequenced them. We found they had a different genome than those in healthy individuals, and we put them one by one in these strains into mice, either those preconditioned with antibiotics so that the bug would colonize, or germ-free mice. And we found some interesting things. Again, these are lupus strains of this common bacteria that everybody in the room has, but in low frequency. And what we found was that these strains from lupus nephritis patients in flare, when you put them in a mouse, they caused increased intestinal permeability. Weirdly enough, it was primarily the female mice. So a bacteria from a female lupus patient causes the gut barrier to break down and high serum zonulin levels. So it's reproducing the gut barrier defect. We actually could track that the bacteria got out of the intestine and into the peripheral immune system. We actually saw that these patients, yes, my small furry patients, these mice developed antibodies that was very specific for these strains. And in parallel, they developed antibodies to double-stranded DNA. And these are C57 black 6 mice. They don't actually develop autoantibodies. So it was really quite bizarre. So just the lupus strains were bad. Those from healthy people didn't do anything. So it's provocative that, in fact, these can have pathogenic properties. Okay, so what have we learned in a very quick fashion? We learned about the gut barrier, that actually the integrity can be affected and regulated by this factor zonulin, first recognized in celiac disease, but now we're seeing clues that the gut barrier is important for the pathogenesis of our rheumatic diseases. So what about other diseases, and what about the pandemic? Is it relevant to how we respond to common viral infections, COVID-19? Inquiring minds want to know. So in studies done at the Mass General, they actually found that children that had evidence of COVID infection, it was actually relatively obscure at first, had a strange thing going on with their gut barrier. And this was within about 4 months of the epidemic being identified on our shores. And I'm proud to say that throughout it all, I was at the epicenter of the North American epidemic. It was just frightening as shit. Really unbelievable. You talk about lockdown, you'd be afraid that you go outside and somebody would cough on you and it'd be all over. So, but in Mass General, they had a systematic approach to this syndrome that was identified nationally in children that is called, and I'm not a pediatrician, multi-systems inflammatory syndrome of children, MIS-C. And you need criteria, so they're children, and they had at least a day of fever that was quite significant, severe illness causing hospitalization, and multi-systems disease, cardiac, renal, respiratory, hematologic, and so forth. But gastroenterologic symptoms were very, very prominent, and that you could draw blood and you could find evidence of systemic inflammation, CRP sed rate, fibrinogen, D-dimers, that there was some coagulopathy, ferritin. Everywhere you looked, you saw this going on. And this is in a setting of evidence of SARS COV-2 or COVID-19 infection, you needed to have objective evidence, RT-PCR, antigen exposure, so on and so forth, and there shouldn't be an alternative diagnosis. So I have to say, here's a mystery, okay? These patients are a little bit heterogeneous, but why is it that these children are getting such an inflammatory condition and they're dying? And you're not seeing this in adults, and most children, it's not affecting them. What is going on? How do you figure this out? How do you, and pediatricians, they have been collecting multi-systems inflammatory syndromes. This is not unusual that little kids get crazy fevers and have multi-systems disease. And so this is a comparison which I don't expect you to be able to look at very carefully. This pediatric MIS-C, and comparing it to Kawasaki's disease, Kawasaki's shock syndrome, toxic shock syndrome. And more or less, the more I looked at this, it did not provide any great clarity to me in that all of these things can be very similar to each other. But the difference seems to be the prominence of gastroenterologic symptoms in these children that really affects them hard, and they really don't have pulmonary symptoms. So they have COVID-19 and gut symptoms, but not like how adults present. So we need a cartoon. So here we have a very sick cartoonish child that has MIS-C, fever, myalgia, all of these, as we say, protein manifestations that look like a viral infection. And then you see all of the organs that can be involved, headache, and actually meningeal symptoms as well, high levels of inflammatory markers. The heart can be prominently involved, and there can be pulmonary infiltrates and chest pain, but this doesn't seem to dominate the picture. The thrombocytopenia, neutrophilia, lymphopenia, and so on and so forth can affect your kidneys, and children die, and they're very sick. And so there was a study that was set up at Mass General. This is to sort of draw all of, I always find these pictures entertaining because usually it means only the speaker actually gets it. It's so complicated, all these things floating around. I won't say I get it. But the part that's interesting here is that there's evidence in these children. They were evaluated in their study at Mass General and hospitalized within 3 days of presentation. Fever and so forth were prominent. Actually, the pulmonary phase, again, that we saw so importantly in adults, was really a minor component. But every major cell could be involved, all the cytokines are involved, and where it affects your body, the systemic disease. And the sort of the implied subtext is all of these things. I mean, there's so many pathways that are in common with our autoimmune diseases, and it's just because there's this overwhelming lesson: inflammation is inflammation. In this condition, very severe, but we have conditions in which we don't know what the cause is, but the same pathways can be involved. So out of chaos sometimes comes order. So here was a paper that appeared in the Journal of Clinical Investigation, and this was in a group led by Alessio Fasano. They evaluated children that had been hospitalized, and really they only looked at 100 children. It was not a gigantic study, 19 of which could meet criteria for MIS-C, and part of the criteria are you don't have any other syndrome. And they found that this was entirely overlapping with evidence of COVID-19 infection, so it was not could never be said to be Kawasaki's or toxic shock syndrome. So they studied them quite closely and found out a number of fascinating things, but I have to say everything is obvious in retrospect. I don't know how prospectively obvious it was. So this is their clinical trial. A patient presents to the hospital, and you get a bunch of blood tests, and you look for a number of different factors, and you also get stool and look to see whether the virus is in the stool. Now, adults presenting to our hospitals, this is not the first thing that we do. Pediatricians obviously have different biases, but one way or another, this turned out to be very important. And the patients that were admitted, again, they only had 19 to sort of characterize and think about interventions. They had to try something because these kids are very sick. And again, I think that a lot of their approach was influenced by Kawasaki's disease, where, again, the idea that here's a bin Here we have our criteria. Now we have a diagnosis. It makes us feel more comfortable. So what the heck is Kawasaki's? I don't know. It's a bin. Very, very similar. It's an inflammatory condition in children, but they had that bin to compare notes with. And what they found was that comparing MIS-C to overt COVID in other kids that were presenting in the classical manner and controls, they had higher levels of zonulin. They also had evidence of increased LPS binding protein. That's another acute phase reactant, just like the soluble CD14. So there's questions of LPS getting into the blood and stimulating this, and so that there's a gut barrier defect. Soluble CD14, just as we had studied, they didn't hit significance, but they actually have a dichotomized group. And how is this group different than the other? And they also found evidence of spike protein in the poop when they looked closely. So this is something quite different. And then they looked for antibody responses, and they found that they were mounting antibody responses to the spike, whether you look at M, G, or A. And they looked over time. They may have been a little bit slow and less dramatically elevated systemic antibody responses. And then they started looking at individual patients. And what do? You treat them with everything you got, try to be systematic, give them, of course, everyone needs steroids. How can you be hospitalized without steroids? Give them remdesivir. It actually seemed to make the CRP angrier, so that was a bad idea. Give IVIG, everybody should have that. Seemed to work, oh well, it's not working. Need a little more steroids, is that doing anything? Well, maybe the CRP is going down. Anakinra, that's good for keeping your CRP down. And the spike is really being unaffected. So these kids have continued antigenemia. This is just one individual, but it's very instructive. And at the bottom, you're seeing that there's problems of coagulopathy and D-dimer, and the ferritin is an inflammatory marker. Is this really responding to any of these things? No, it's just kind of hectic and who knows what goes on. So here they bring them, I'm joking now. Now, lorazepam, the magic bullet. And you go, oh, that's a really great idea. They've used every other big gun they can, and then they give them a nonapeptide by mouth that isn't even absorbed into the body. That's a great idea. And what happens? The CRP, the spike, all goes down. The D-dimer gets better. And if you look at each of these cytokines, inflammatory cytokines, IVIG, I'm not so sure. They drop a little bit, but they stabilize. The steroids don't do anything. But look at the lorazepam. Now, as you all know, you have to be a little skeptical because if that didn't happen, it would never have been published in Journal of Clinical Investigation. But all of this is actually quite provocative because lorazepam has no toxic effects. It can't hurt you because when it works, it seals itself in your intestine. And it actually is degraded by the time it gets past the biliary duct, and it's digested by all the proteases that are there. So, okay, this is the finale. This is what they're telling you. So you think about it, the gut barrier influences everything, and in a certain set of very, very sick children, their infection may well be biased, that actually where the virus goes is more in the intestine. I assume that means that it's proliferating there, and the RNA is there, and it's actually persistent. And that the effects of the virus and its products, and also there's a dysbiosis, and there is a shift of bacteria, I should mention. And by the way, one of the shifts is it induces expansions of Rheumatic novis, but I'm not going to talk about that at all. I won't even mention it. But there is loss of tight junctions, and all of the nasty bugs and all of their products like LPS and lipoglycan is actually leaking into your body. So you have a viral infection that's doing nasty things, and then you have the screen door in your gut. And spike continues and the hyperinflammatory state occurs. So they also make a big deal out of a superantigen motif, which is just activating a lot of T cells inappropriately. All right, so what have we learned? Well, I think that wherever you look, even in health, the human gut barrier is important, but it's not impregnable. And that zonulin-mediated regulation of gut epithelial tight junctions influences host response to dietary antigens, gluten, and the epidemic of gluten enteropathy, and how every pizzeria has to have gluten-free pizza. But that's another story. Maybe it's not your neighborhood. And all this can result in release from the gut lumen of inflammatory factors. George Schett says that it actually relates to the transition of benign antibodies in your circulation to overt inflammatory destructive rheumatoid arthritis. And now it's been implicated in SLE pathogenesis and disease flares. And that, in fact, it also is important for common infections. Luckily, this infection is not as common as it was just a little while ago, or we wouldn't all be here together. And that it subverts host immunoregulation, and this may be central to this horrendous syndrome in children, MIS-C, and there's now a randomized controlled trial being conducted. Luckily, the frequency is less and less. So that's what I have to present today. Everything is connected by the gut barrier, and hopefully there's better treatments on the horizon.
All right. So, so much to talk about, so much to think about, so we'll save this till after Dr. Looney is going to join us. Dr. Looney is one of the stalwarts of this meeting. He is an immunologic polymath, trained in allergy, infectious diseases, and rheumatology. And I asked him what was interesting for him today, and he said insights into lung disease and juvenile and adult onset Still's disease. So I'm just waiting to hear this.
And the underlying text was, this better be good. Let's see, forward. So this caught my eye that we may be dealing with a new disease, or at least a disease that's become much more frequent. I think that's sort of a worrisome kind of thing, but it's also something that, you really have to jump into and try and get your head around. And so, in kids with systemic onset juvenile JIA, they can get lung disease, and these are shown some CT scans from a paper in 2019 that was reporting on these. The overall things that I'm going to talk about in this talk will be the clinical presentation of systemic onset JIA with lung disease, how the innate and adaptive immune system are activated, and then something about that's already been mentioned already, this pulmonary alveolar proteinosis, which is part of this syndrome, and then some really provocative studies that were done to suggest that this might actually be an allergic reaction, that people are having drug-related eosinophilic systemic symptoms as the etiology of this lung disease, and they were responding to the drugs that were being used to treat the systemic onset JIA. So if this is all true, it's pretty concerning. This is some data showing that in one center, the lung disease per year has gone up dramatically in the last 20 years for unexplained reasons. It may be difficult to explain this on the basis of missing this syndrome in all of these kids. The other thing is that the frequency of lung biopsy showing pulmonary alveolar proteinosis or endogenous lipoid pneumonia, which is a very similar kind of disease, the percentage has also gone up. And the concern here is that this systemic onset JIA with lung disease is very lethal. Here's the survival curve in kids that present with this disease. So this is obviously something we've got to figure out. So what's shown here in the upper left-hand panel is the typical rash of systemic onset JIA, the macular erythematous fleeting rash that's here and then gone and often correlates with the fever. These kids with the lung disease are getting a different kind of rash, atypical for SOJIA. more indurated. This is not a rash that's coming and going. It's coming and it's staying, and it's often very edematous and indurated. And then you're getting these very strange manifestations shown here. You can get clubbing of the fingers or the toes in these young infants, and you also can get this erythema of the distal finger. So very, very striking and unusual presentation for SOJIA. Some of the other things that were correlated here, I don't know how to get rid of this. Is that on your? No, it's not on there. Okay. Is the risk factors for this include a young age, the younger the more likely, trisomy 21, and interesting anaphylaxis to tocilizumab. Other features include eosinophilia, lymphopenia, rising ferritins, and drug hypersensitivity. And this is another group that published similar data. The way this is set up is each one of these quadrants compares kids with lung disease versus no lung disease, and this is a frequency of risk factors. So you can see the odds ratio for some of these things is quite high, 6.5, 14.5, 13.4. So the risk if you're less than 2 is markedly increased if you have had a history of an adverse drug reaction or if you've had a history of MAS. And this is the difference in the IL-18 level in people with this lung disease or not lung disease is markedly higher in the people with lung disease. And this is to show that the adult onset Still's disease also has something that looks very similar. They get an interstitial lung disease. It's associated with a decreased survival. It's associated with a high disease activity, but interestingly, it's actually the older individuals that are increased risk. And in this series, at least, which is from Italy, there was no clubbing, no atypical rash, and no adverse drug reaction. So you may be able to get this lung disease without having some of these other features. So we want to talk about immunology, and so I think people are very familiar with the mechanism of inflammasome activation, but just to remind everybody, you've got usually 2 signals. The first signal, which can be toll-like receptors or cytokines such as IL-1 or TNF-alpha, which are both primary cytokines. Those signal to the nucleus, and you get transcription of mRNAs and translation to proteins, including this inflammasome, the proteins involved in putting the inflammasome together, and also pro-IL-1 beta and pro-IL-18. These are not biologically active until they get activated as a second signal, where the proteasome actually cleaves this peptide off, and then the IL-1 beta and IL-18 can be released and have biological activity. Interestingly, of course, you have a feedback loop with these inflammasomes. Where the IL-1 is produced, it can actually go back here and induce the production of more protein, and so blocking the effects of IL-1 by giving IL-1 receptor antagonist, which is a recombinant naturally occurring protein, anakinra or Kineret, can be very effective in these inflammasome-mediated diseases. And Virginia Pasquale was very instrumental in showing that this kind of drug could be very effective in systemic onset GIA. So IL-18 is also produced by the inflammasome, and in systemic onset GIA, it can be very high. This is looking at healthy controls, systemic GIA without MAS, systemic GIA with MAS, and these are a couple of different types of HLH. You can see that the level of the total IL-18 is sky high, orders of magnitude higher than in normal individuals. There's a binding protein that inactivates IL-18 systemically, and that often also goes up. But the amount of free IL-18 is very high in both systemic JIA and even higher in MAS. When people with systemic onset JIA, sort of the underlying long-term problem is this activation of the inflammasome, and you get this IL-18. But then you can get these episodes where they get MAS, macrophage activation syndrome, which can be lethal. cause all sorts of complications. And when that happens, what you see is the adaptive immune system is also activated. So this is looking at flow cytometry. The CD38 is on this axis, the HLA-DR is on this axis. So these are both activation markers for lymphocytes. So if you look at CD3 positive cells, so they're T cells and they're expressing CD8, so these are your cytotoxic CD8 T cells, although in this case they're not very cytotoxic. In active JIA, you don't have a lot of these activated cells, and even in activated systemic JIA, you don't have them. But when you get MAS, you get this enormous expansion. You also see it in other diseases where you get HLH. And in the MISC, you can see this expansion as well. So this is something has triggered the activation of these T cells, and they become markedly activated. And these T cells here, pictured here, are these activated T cells are secreting large amount of cytokines, including interferon gamma, which seems to be critical for the production of macrophage activation syndrome, and they're not very cytotoxic, so you're really not getting rid of the macrophages that are so activated and giving you hemophagocytosis and cytopenias and other manifestations. So what IL-18 is doing when it's produced by the inflammasome is it's being released. A lot of it gets inactivated by this IL-18 binding protein, but if there's a disconnect between how much IL-18 and how much binding protein you produce, you have a lot of free IL-18 that can then bind to its receptor, which is a little bit more restricted than the IL-1 receptor. But some of the cells that it's on include T cells and NK cells, and its original function seemed to have been increased production of interferon gamma. So this is a way to really sort of turns the amp up on T cells so that they become markedly more activated. And of course, the interferon gamma can bind to the interferon receptor and activate the JAK-STAT pathway. So, and if you look at lungs from individuals who have this systemic JIA with lung disease, that's shown over here. Here are some normal lungs that they were lungs that were for transplant donors that were apparently not suitable for transplant. And these are the lungs from the systemic onset JIA with lung disease. You can see by this heat map that there's a big difference between these lungs, and a lot of that is explained by activation of the gamma interferon pathway. Here are some of the individual cytokines. Two of the ones that people may or may not be familiar with are these chemokines, CXCL10 and CXCL9, which are induced by interferon and actually recruit interferon-producing cells to tissue. And this is a network analysis showing that a lot of the activation in this lung centers around this transcription, or this transcription factor STAT1, which is immediately downstream of the gamma interferon. So there's really good evidence that the gamma interferon pathway is activated in these lungs. So let's talk about pulmonary alveolar proteinosis, which has already been mentioned. It can be caused by an antibody against GM-CSF. The lungs in people with systemic onset JIA with lung disease, you can get pulmonary alveolar proteinosis, interstitial lung disease, and pulmonary hypertension. But this is the one that seems to be predominant, and this is the one that's become even more frequent over time. Just to look at what happens when you have this, this is a BAL, and you can see you get all sorts of the material in the BAL. You have these macrophages that have these vacuoles that are all these lipid material, and the alveoli are filled up with eosinophilic material. So this is how you have your respiratory failure. And this is looking at a lung from somebody with systemic onset JIA with lung disease. You can see these areas that are starred or full of lipids. Some of that is shown over here. You get air spaces filled with the foamy macrophages and eosinophilic material. You get type 2 alveolar cell hypertrophy, and you get a lymphoplasmacytic infiltrate. So, as mentioned before, this is sort of what normally happens to lipids in the lung. You have this phospholipid interface in the alveoli. You have these type 2 alveolar epithelial cells that make these lamellar bodies that form this lipid layer. And as this lipid gets damaged, it gets degraded, it forms aggregates, and the macrophages pick that up. The alveolar macrophages pick that up and digest it. But both the type 2 alveolar cell and the alveolar macrophage have receptors for GM-CSF, and that augments their function and allows this to happen normally. If you develop antibodies against GM-CSF, you have this dysfunction where you can't degrade these inclusion bodies, or you could have a defect in the receptor itself as a genetic form of pulmonary alveolar proteinosis. And this is just showing examples of the anti-GM-CSF antibody in people with autoimmune pulmonary alveolar proteinosis. They have it. People with systemic onset JIA with lung disease do not. And this is looking at the function of the receptor. STAT5 is downstream of the GM-CSF receptor. There's no defect in these individuals in terms of the receptor. So you really need a new mechanism to explain why these individuals get pulmonary alveolar proteinosis. So this takes us, again, to some immunology. There's a subset of T cells, Th1 cells, and they make gamma interferon. The transcription factor that drives this is T-bet. And so if you have this level of the T-bet in the T cells, whether they're CD4 T cells or CD8 T cells, determines how much Th1-ish they are, how good are they at making gamma interferon. And so the higher the T-bet, the more these cells are going to be likely to make gamma interferon. And so what a group did is they made a mouse with T-bet overexpressed in T cells, and they looked to see what happened. And so they had the wild type. This is looking at survival over a lifespan of the mouse. And the wild type, or with just one copy of the T-bet, the mice did fine. But if you had two copies of the T-bet, in other words, twice as much as the heterozygote, survival was dismal. And if you looked at what happened, the BAL from these mice has had this cloudy material, and if you look in the alveoli, they're full of this proteinaceous material, or this eosinophilic material, which is lipid. If you look at the lungs of individuals that have pulmonary alveolar proteinosis, this is somebody with the autoimmune type, and this is somebody with secondary PAP. This is not due to the systemic onset JIA with lung disease, but this is myelodysplastic syndrome, which is sort of the most common hematological abnormality that gives you PAP. And interestingly, you see sky-high levels with this in the secondary PAP. I haven't found this data in patients with systemic onset JIA and pulmonary alveolar proteinosis, but I'm sure it's probably impressed someplace. So this gives us a number of targets that you could use if you're trying to treat somebody with systemic onset JIA with lung disease. You could go after the IL-18. You could go after the gamma interferon. You could go after the activation of cells by gamma interferon with a JAK inhibitor. So this was a real shocker to me. The severe delayed hypersensitivity reaction to IL-1 and IL-8 inhibitors linked to HLA-DR beta-1 15 alleles. And what they posit here is a DRESS type reaction occurs among people treated with IL-1 and IL-6 inhibitors for systemic onset JIA, and this is associated with this haplotype, and that this is explaining this lung disease. This is just to remind people, I do allergy as well as rheumatology, so we're often called to see some of these individuals with DRESS. They get this very characteristic rash, and this edema of the face is something that is seen in most of these patients and is not seen in a lot of other drug reactions. These are some of the criteria for the diagnosis of DRESS. Fever, enlarged lymph nodes, eosinophilia, atypical lymphocytes, a lot on the skin rash, organ involvement, slow resolution of the rash. So this isn't like amoxicillin, you stop it and a few days later the rash starts to go away. This is something that really sticks around, and then you have to exclude just about everything else. Importantly, a lot of these manifestations also would be found in systemic onset JIA, especially if you had MAS. If you look at individuals who have Still's disease and these allergic reactions, most of those individuals fulfill the criteria for DRESS. The other thing about DRESS is that a lot of it is HLA linked. So these are some drugs that cause DRESS not infrequently, and many of them are tightly linked to certain HLA groups, like allopurinol with one of the HLA beta alleles. And what, in some cases, not in many of them, but in some, they've shown that what is happening with DRESS and these low molecular weight drugs is you're actually getting altered peptide. So in other words, the drug actually fits into the pocket that binds peptides and presents them to T cells. And so all of a sudden, your antigen presenting cells are presenting new self-peptides that they'd never seen before. And of course, that is recognized as allo, and all of a sudden you're activating a whole bunch of your T cells because of that. And so you get this tremendous activation of the immune system that causes stress, which is frequently fatal. So this group collected a lot of these people with HLA, with DRESS. In other words, they fulfilled the criteria for DRESS, and they were all on IL-1 or IL-6 inhibitors, and they looked at individuals who were on these inhibitors and had Still's with DRESS or didn't, and compared the HLA DR beta 1 1501. And there's this tremendous enrichment here. There's no question that this is an HLA-related disease or manifestation, and they did that. They sort of sliced their cohorts a number of different ways to try and match them better. But anyway, they sliced them. They got this dramatic enrichment. So you know, the question is, what's going on here? This DRESS hypothesis posits that IL-1 and IL-6 blockers are somehow altering antigen presentation with this particular HLA type, and that's causing a expansion of Th2 cells and this systemic onset JIA with lung disease and MAS. Okay, but there's a lot of problems, at least from the point of view of saying that this is a drug reaction. For one thing, often the patients can continue on the drug. This would never happen with regular DRESS. You know, when people who have had DRESS get re-exposed to the causative drug, the disease explodes, and you know they can't do that. This is not a syndrome where you can desensitize people. So that's a pretty strong argument against this. You know, it's in rheumatoid arthritis, in other rheumatic diseases, we're using these same drugs and we're not seeing DRESS. And yet there's HLA, DR15 in those individuals, so that doesn't make any sense. It can occur in people with systemic onset JI who've never been on biologics. The idea that the multiple biologics are all behaving with the same HLA, even though the peptides presented would be different, seems odd. There's also, you know, because the manifestations are similar between systemic onset JIA and DRESS, probably the criteria for DRESS are really not as specific as you would like in this population. So you have to discount that a little bit. And the other thing is that this HLA-DR beta 115 is associated with a lot of other things. For example, it's associated with multiple sclerosis. It's associated with Goodpasture syndrome. It's associated with allergic bronchopulmonary aspergillosis, drug-induced hepatitis. It's actually protective in type 1 diabetes. And it's got a funny relationship with EB virus. Actually, the titer of the virus is expanded, and there's more immune activation in individuals that have this HLA type. So So this is a peculiar HLA type, and there may be other things going on. So there's this cytokine plasticity hypothesis where you're saying that you've altered things, and so now all of a sudden, you know, you instead of having this dramatically Th1 environment, this Th2 cells can creep into the picture. And so interestingly enough, IL-18 is best known for promoting Th1 cells, but it actually can promote Th2 cells as well. And there's a group in Japan that's been working on this for a long time. So if you have high IL-18 and you have high IL-12, which is sort of the cytokine that induces Th1 cells, you get interferon gamma. But if you have low IL-12, then if you're in a low IL-12 environment, then all of a sudden high IL-18 can actually induce Th2 cells. What's interesting is that that IL-1 beta is actually one of the cytokines that can induce IL-12. So here's just showing that. Here's a stimulus for immature or mature dendritic cells, CD40 ligand. If you add IL-1 beta, you get about a logarithmic increase in the amount of IL-12 produced. And of course, what are we doing when we're treating patients with JIA? We're giving them an inhibitor of IL-1, so we may be downregulating the IL-12 production on the basis of this. The other thing is that this Japanese group has this idea of a super Th1 cell. So it may be that it's not like you have Th1 cells and you have Th2 cells. You may have a T cell that has both characteristics, and maybe that's why it's so pathogenic. The other thing that's really news to me was that IL-18 can activate eosinophils. So these are in activation markers so regular eosinophils don't express CD101 or CD274, but pathogenic eosinophils, ones that migrate into tissue and cause damage, do. And if you incubate regular eosinophils with IL-18, all of a sudden you get this upregulation of the CD274 and CD101. So, you know, if you have some kind of an allergic response, you make IL-5, you stimulate eosinophils, you get some peripheral blood eosinophilia. But if you have high levels of IL-18 there, then all of a sudden these eosinophils have become much more pathogenic, and maybe they're causing some of these manifestations. Okay, so in conclusion, the pathogenic hypotheses for this new syndrome are that Th1, T-bet, gamma interferon are key for macrophage activation syndrome seen in systemic onset JIA, and probably for the lung disease, and that IL-18 is also probably playing a key role in driving this response. But then you sort of have another hypothesis, which is this Th2 may be key for the eosinophilia, atypical rash, and the clubbing, which is seen in kids, but is not really seen in adults, at least in the Italian series. And this seems that IL-18 may also be playing a key role in driving this response. It seems to be related to the HLA-DR15 allele very strongly. It's associated with drug hypersensitivity. And, you know, the question is whether all of this Th2 type of response is really related to the lung disease or not. I mean, it maybe is responsible for the atypical rashes and for the clubbing, but maybe not the lung disease. And I think time is going to have to tell us whether that's true or not. If it is pathogenic, then we've got some pretty good drugs to go after Th2 responses. So this therapy so far for this systemic onset JIA with lung disease is totally anecdotal. They've used steroids, just jack them way up, and that seems to help. But oftentimes it comes back as you taper the steroids. People have also combined it with higher doses of IL-1 or IL-6, or changed up and gone from one to the other. They've used JAK inhibitors, they've used anti-gamma interferon, and there's this interesting monoclonal that blocks both IL-1 beta and IL-18. It's a dual specificity monoclonal, and that also seems to work. So sorry if I'm over time. I'm going to stop here. There's a summary slide up there. If there are any questions.